Welcome to the IMI Health Hour. This is a lecture series on the subject of bioethics, which we are developing with the intention of incorporating it in our major project that we're doing with globally renowned ethicists in the name of Encyclopedia of Islamic Medical Ethics. It's a monument of stars, but I'm sure, inshallah, with the help of Allah subhanahu wa ta'ala and Mother of Ahlebait Tv, we should be able to accomplish it. We have identified about 110 topics and about 100 or 110 writers from different universities across the world. And the objective is that we develop this encyclopedia for long-term reference, more like a reference book for people who want to do any kind of work on medical ethics. Therefore, it incorporates ethicists and scholars and research scientists from the West as well as from the East. A lot of countries are involved in it, and inshallah it will be something really worth the effort. So this is a part of series which we are gathering material, doing referencing and literature search and whatever is needed in the initial stages. And this is a part of my talk. So last time I talked about various aspects of Islamic biomedical ethics in relationship to practices that currently are in vogue in the UK. Today I'm going to talk about patient-physician relationship in day-to-day practice, and I'll try to cover the Western model as well as the Eastern models because I have worked in those different regions. Now, the important thing to remember is that in medical practice, whether you're a physician or a health practitioner or a nurse, the most important person is the patient. And it's our objective in life, in medical profession, as a part of ethical oath, that we must honor and give due dignity and respect to the patient, and whatever we can do to relieve his sickness or ailment. In this series of relationships between patient and physician, there are different aspects, different subjects, topics we have to cover. So I'll try to cover some of them in this lecture, and probably will continue in the series as it goes on. So there is an important thing called patient-physician or the physician-patient relationship models, and I'll talk about 4 models which are currently in vogue, but they are controversial because people always come up with fresher concepts, and every time you come with a model, somebody will come and say, and do the critique and modify it. So I'll give different examples of the models. Then the important subject is the treatment of one's own family and friends as a physician or health worker. Then what are the patient's rights and responsibilities? What are physician's rights and his responsibilities? And a very important topic is that of conflict of interest that comes into play in many fields, particularly if you're a physician practicing in different areas, and you have people who come for different reasons, like pharmaceutical companies or drug trial companies, or people who are making different gadgets. So I think that's an important thing that we'll discuss as we go on. Then the important thing is accepting gifts from patients, particularly in the Eastern culture. It's a very important subject that has to be kept. But also in the West, it's a topic that we need to cover, and I'll try to cover in one of the discussions, not today, but in the future. Then referral of patients to other institutions. Many times you cannot cope with these patients, the patient that you have, and he needs further evaluation, advice, and management. So what is the criteria for patient referral to different institutions, even to colleagues in different fields? And it's a very common thing in clinical practice. We do it all the time. One must know his limitations. Going beyond one's limitations is unethical. You must understand that you cannot be competent and capable to cover everything that's there. Medicine is exploding every day. What you learned yesterday is already obsolete. Therefore, it's important that you remember that what are your capabilities and work within the capabilities that you have. So referral of patient to other institutions and colleagues is an important thing. That is a very controversial subject. I was listening to Radio 4 yesterday, or some radio yesterday. There was this discussion about this particular thing that happened somewhere. But patient-physician's romantic relationship, that is an important subject that we'll try to cover. Now, telemedicine has caught on very rapidly in the last few years, and IMI is running its own telemedicine program program across the world, particularly in remote areas of Pakistan, in Gilgit and Baltistan, and some areas of Karachi and Lahore. We have a regular series of lectures, discussions, consultation, educational activities. My dear friend Fahim Nanjiani is in charge of this project, and what we're trying to do is we're gathering doctors from across the world and patients who are selected by our colleagues in different regions of the countries that I've mentioned, where once a week or twice a week we have consults on, and that is an important subject. But what are the ethical issues involved in telemedicine? That has to be kept in mind. Then any person, we're all human beings, we can commit mistakes. So how do you manage those medical errors? And this is an important thing to remember, because one has to identify the error and correct it as far as one can and learn lessons from it. Then the relationship between patient and physician in financial terms. It's of immense importance now that private practice is growing rapidly in the Western countries, particularly in the UK, and has been the major focus of or major source of medical care in the Eastern countries that I have visited on many occasions, like Iraq or Iran, and of course where practice like Pakistan, of course very common in India and Bangladesh and all these countries. So what are the ethical principles of this kind of relation that we'll try to cover during the discussion of the series of lectures? And then we have to remember the prospective care codes, which are, some of them are ethical codes, some are standard codes which are developed for research and other things. Then the important thing is that if you are working in a group practice, how do you distribute the income? Or you're working in a hospital which is private setup, how do you have an arrangement of getting your due without compromising other people's rights? Then there are unofficial payments, which are very common in the developing world, and I'm sorry to say that this is something that has to be looked at very seriously. Then self-referral. I mean, many times you refer the patient if you're working, say, in a government hospital. Very common in Pakistan. I've seen it myself. You work in a state hospital, because you happen to be the consultant, you refer the patient to your private clinic or private lab or diagnostic services to your friend or colleague at a certain financial advantage. Now, this financial benefit. Now, this is something that one has to look at very, very carefully. It's happening in the UK as well, where some of the consultants who work in the NHS as the state, as the employee of the NHS, have gone into private practice. A certain element is allowed, but then beyond that, if you do self-referral or ask your colleague to refer to you at a certain monetary benefit, now that's an issue that has to be considered in this kind of patient-physician relationship. The most important element of the discussion is informed consent. Now, informed consent is the parameter which determines different things. It is the spine of autonomy. Autonomy is one of the 4 pillars of medical ethics, and I'd like to cover that subject separately in one of the lectures, which may take at least an hour, maybe more, but that will come later. Then confidentiality is an important thing. What patient tells you as a physician or what doctor or the nurse comes to know during the discussion is totally confidential. There's a covenant of trust, a mutual understanding, almost like a faith, a solemn oath that you take, and whatever you, as a physician or a nurse, you come to know about the patient's personal or financial or health issues, of course, that must remain confidential. That's an important thing. And then privacy has to be maintained, and we'll talk about privacy in terms of consultation as well as long-term management in clinical practice. Now, the important subject to remember, the topic that is a very, very salient topic in the discussion of patient-physician relationship is professionalism. What is professionalism? People have defined in different ways, and there is a complete chapter that we are writing on professionalism in the encyclopedia. It is the relationship between the patient and health worker of commitment to excellence in service with mutual respect and fairness. Now, fairness is an important thing, and that we'll discuss under the topic of justice when it comes to the question of distribution of resources, etc., and that is a topic in its own right. But professionalism is an important element in medical care, and that is a subject that I'll try to cover at some stage, or maybe today, part of it. And of course, we have to remember that between the patient, the physician, and between the healthcare worker or nurse or associate specialist or whoever and the patient, it's a lasting relationship, especially so in the family practice, because family practice is almost like a family member. In the specialized services where you deal with the patients as a specialist, the matter is slightly different because you don't have a regular encounter with this patient. But family practice, you're the hub. So it's important that as a family practice, you have constant, lasting relationship which is based on mutual respect, love and affection. And this is what I've mentioned here, that mutual respect, dignity, honor and thorough professionalism remain the founding bricks under all circumstances, whether a family physician, a nurse practitioner, associate specialist, a consultant or a professor. It's important that there should be mutual respect and dignity. And this is what I mentioned here, the trust is the founding brick. You build the edifice, the structure of the relationship on trust. If there is no trust, it's going to fall out. They will not have any virtues and you will not benefit, you will not be able to serve your patient, and the patient will not benefit because there is no trust. When a patient visits a physician, a nurse, or health worker, he comes with full confidence and trust in the ability of the profession, and that is professionalism, and the trust is a part of professionalism, and unless you develop the trust, it's going to be difficult to maintain the relationship. In return, he expects to be treated with respect and dignity and confidentiality. Breach of any of these elements will compromise the ethical principles of relationship between a health worker and the patient. So the important thing is there should be mutual respect, dignity, trust, confidence, confidentiality, and above all, professionalism in healthcare. Now, this is what I referred to earlier on. There are 4 models of relationship that I'll give the reference of this particular writer who's to me they are very attractive and I rather like them. The first model is called Paternalistic Approach, where the physician, because of the trust and confidence, because he is the patient has full confidence, ability and professionalism, physician makes the decisions for the patient's benefit independent of the patient's values or desires. Now, this has been the traditional approach for a long time in medicine, particularly in the Eastern countries, also in the West, that because there was mutual trust between patient and the doctor, the patient would come and say, look, doctor, you know best. You are the doctor, you are a professional, I have full confidence in your abilities and your capabilities, and I trust your decision. So this is called paternalistic approach, still in vogue in some situations in the Eastern countries, in India and Pakistan, Iraq, Iran, everywhere, but also to a certain extent in the UK. But it has changed because of the explosion of knowledge, technology and skills, and paternalistic approach is almost as good as gone, at least in the UK. The next model is called informative model, where the physician, you have consultation and discussion. The physician provides the information, patient applies values and decides. So determination is kept. The patient basically is given all the information about the disease, the plan of treatment, prognosis, and I'll go through these steps in a moment. But the important thing is that the patient's role, the physician's role is to inform the patient, and that is fully informed patient. The patient has to be given full details and different aspects of treatments, different values, different disciplines, which are alternate medicine if it's available, any other thing that can be carried out. But the decision has to be made by the patient, not by the physician. The third model is interpretive, where the patient is uncertain about the values. The physician then works as a counselor and assists the patient in elucidating his or her values. Now, values means that you have discussion about the disease, what could be the outcome, what investigations are needed, what will be the final results, will it need any rehabilitation, all these things, plus the cultural aspects have to be counted. We cannot undermine the importance of culture in medical ethics. Although at some stage we'll talk about that when it comes to cultural ethics. But right now, let me say that the job in interpretive model is the patient doesn't know what the disease is going to lead to, so patient works as a counselor, as an advisor to assist the patient in understanding the values. And then finally is deliberative, which is a formula where patient is open to development a physician teaches a desirable value. So, for example, if somebody has a condition like, say, an acidity or reflux, the patient is given all the information by the doctor, and then doctor gives them an advice that, look, in my view, this is the best line of treatment. So, decision still by the patient, but physician gives guides towards the final path of treatment. And this is the reference, which is a very important reference that I've mentioned here, where I picked up these 4 models. Now, these are, to me, they're quite attractive models, but I like the deliberative model where you discuss with the patient all the disease, the prognosis, long-term management, etc. And then you guide him, because a lot of patients don't have all this. Of course, knowledge is expanding, and now, of course, different search engines are available. Patients are very well informed. But in the developing countries, still there is a lot of things one has to learn. So that role, deliberative role, is an important thing, where patient is open to understanding, development, discussion, debate, but decisions should be made by the physician, by the patient. The physician's role is that of like a head of the family, like an elder brother. Look, this is the discussion, and my view is that this is the approach that will be most suitable for you. And this is, I think, important, because the understanding, the trust and confidence between the patient and, like I said at the beginning, the mutual trust is the founding brick of the relationship. That's the reference of this particular paper which I picked up. Now, this was argued later on by somebody else, and I'll give the reference in a minute. So they said that there's no more models. Patient-physician relationship is constantly evolving, because knowledge is expanding, skills are expanding, availability of resource material is so much. So currently, the common theoretical models of preferred decision-making relationship do not correspond well with the clinical experience. And I think partly it is true, because the paternalistic approach is no more applicable. Informative still to a certain extent, but deliberative is quite good. So this particular author and writer, I'll give the reference towards the end of my lecture, says that you cannot have a preference in terms of models. So according to this particular writer, and this is the reference here, no single model of physician-patient decision-making should be preferred, and that physicians should first ask the patient how they want medical information and decision-making to be handled. Now, this is of particular importance in the developing countries, where the knowledge, where patients come from different villages and different areas, remote areas, and they're not knowledgeable, and they have full faith and trust in the doctors. The doctor's job is to advise them, give them guidance, provide whatever information, and that thing, again, deliberative model appears to appeal to common sense. But of course, in the developing countries, paternalistic approach is still very popular. But in the UK and in the US, for example, this is an article published in the American Journal of Bioethics, which concludes that no single model of a relationship is preferred, and the discussion should carry out after a history and clinical examination as to what and how would the patient like to be informed, and decision make with joint discussion. Confidence is one of the major tasks of physicians to take the patient into confidence by going through the findings, diagnostic tests that may be required, the plan of treatment that he has in mind, alternate options that should also be discussed, because surgery is not always the best choice in certain situations. So you discuss that, look, you have an option of surgery in certain conditions, but there's also medical treatment, and there are, of course, different other therapies that are available in the arsenal of treatment. And of course, one has to discuss, like I said at the beginning, any onward referral or discharge from the service. This should be clearly demarcated and identified. We're using System 1 at the moment, which has a kind of allegorical approach, and you go stepwise, and then you come to a stage, either you refer to a department or to a hospital or further investigation, or you discharge the patient. Decision has to be made and should be conveyed to the patient, because there should be no doubt left in consultation. The patient has a right to gain all that information is needed, and he can raise questions, and you have, as a physician, as a health practitioner, you have to give the answers. Excuse me. A physician is duly obliged to provide satisfactory answers. Now, sometimes, and it happens to all of us, you cannot have everything, you cannot know everything about the disease or whatever. So the answer is that you say that categorically that, this is the answer I have, but if you have any questions, I'll go back, read it, discuss it, find out from my resources and come back to you. So leave your phone number, I'll call you back, or the patient can get an email and you can discuss. It's of immense value in general practice, where telephonic consultation is very commonly carried out and the questions are asked. Also, in specialist practice, you have to, if you have no answer, well, give the answer after going through at a later stage. You may not be able to answer on the first in the first consultation, but you can go back, read it, find the answer from your resources and give an answer. It is always advisable to encourage the patient to ask any relevant questions to satisfy himself, because if there is any doubt, if there is any deficiency, and after those 10 or 15 minutes of consultation, it goes away with something in the back of the mind that, look, I should have asked this question, I should have. So it becomes a bit of a nuisance. So the best is to discuss, encourage the patient, and the patient has a right to ask as many questions as he wants. Of course, there is a specific time, and I'll talk to you in a minute about the time allocation, but try and give as many, raise as many questions as the patient, and the doctor has to give as many answers as he can. If he cannot, then you go back and come later on and through the email, or that email has to be secure email, or through telephonic consultation. Now, the important thing is, and this is one of the important things that we've been taught and we learn and teach all the time, time economy is important. You cannot have consultation for hours and hours and hours, so there has to be time allotment. In general practice currently, about 10 minutes is supposed to be adequate enough for a patient to give the history and the initial consultation. Of course, later on we comes back, you'll have another 10 minutes, or sometimes it can be more depending on the disease or the findings. So in general practice, the 10 minutes for consultation, examination, arrangement of tests, because all electronic, it's a paperless work these days, so it just goes straight away as you take this, you're also making the notes. And then, of course, you tell the patient that after we've done the consultation, I will send you for certain tests and we'll just see you back with the results. At the specialist level, currently the time slot is 15 minutes, sometimes it's 20 minutes. In more difficult situations like cardiac cases, or for example in oncology, it could be 20 minutes or even half an hour. But generally in routine specialist practice, it's 15 minutes is supposed to be adequate. Though I know some people do it in 7 minutes, which I think is a bit less. I think 10 to 15 minutes is a reasonable time where you can take comprehensive history, do the clinical examination, arrange for the test, and the patient also feels satisfied, and you should make sure that that time allocation is carried out properly, because there is no need to hurry. There's plenty of time. Patient has full right to use that time, and patient is also encouraged to use that time to the fullest, because there is a slot and one has to work for X number of hours and one is paid accordingly. So therefore you must be fair in giving full 15 minutes if you're a consultant and 10 minutes to a general practitioner or health practitioner to the patient. And then, of course, a follow-up is arranged if necessary. Follow-up could be 10 minutes, and that I think is a common practice, unless there's something more to be done. Now, generally we've seen in the UK, I cannot say the same for the developing countries where there is no concept of time allocation, which is sad, and one has to encourage and train and teach the patient to know that time is of essence. Now, most patients know the time allotment, but sometimes it may be advisable to mention how much time they have, so they can prepare their questions and discuss with you and ask any questions. So time economy is an important subject to remember. Now, currently there's a lot of pressure on the NHS, and I'm talking about the NHS because I work in NHS, but in private sector, in other countries, the waiting list could be even longer. I know in Pakistan you have to wait for hours and hours to see the doctor or consultant. If it's a professor, that's even worse. So in the NHS, there's a long waiting list of the patients, and more often not, there might be delay in the waiting. So if you are sitting in the outpatient waiting what's going to happen, well, because sometimes the consultation can go on for longer, one has to be careful in time allocation, and sometimes we announce it, I'll talk to you in a minute. The private sector has grown very rapidly in the last decade or so in the UK, where services are prompt and well organized. but they're expensive and not everybody can afford it. Health insurance is gaining popularity in the UK. In the US, of course, you have to have health. Everybody is obliged to have health insurance, otherwise you cannot. Of course, there are state hospitals and Medicare and things, and I'm not competent enough to talk about the US system, so I'll leave it there. In many developing countries, state hospitals have no appointment system, nor indeed an allocation of time. So you just walk into the outpatient, the university hospital that I worked in, the patient would just come in. You see them as they come in. So there is no time allocation. You cannot justify that. Many times you're either hurrying up or you're taking too long to discuss a case. If you're a teacher and you have students along with you, you may spend hours on one patient and only a few minutes on the other. Now, this should be fair distribution of time, and that is an important thing. Private health schemes are becoming increasingly available to those who can afford them. State-sponsored health cards are currently being introduced in Pakistan, which is a welcome thing because that was badly needed. Health insurance has been there in certain aspects and certain quarters of the population, but not to the general public. But it is being facilitated by the present government, which is a wonderful news. It is a common practice in a busy hospital outpatient, whether it's a community hospital or a tertiary care hospital, that there might be some delay. So if there is a delay, it is best to announce it. That's the job of the receptionist or nurse in charge, or somebody who's taking care of the patients as they come in to the reception, to announce it that there might be a delay of X number of minutes because the clinic is running late or whatever, because patients have to wait and sometimes you have to park, and parking is a great nuisance, particularly in the major cities like London or Birmingham or Manchester or Edinburgh, and I'm sure elsewhere as well. And the NHS charges parking fee, which is considerable, to say the least. So I think one has to remember that you announce if the clinic is running late, it should be announced that the patient can, so they can arrange if they have to make alternate arrangement for, or maybe pay or come back or whatever. Now, this is a new concept which I'd like to emphasize, called community outpatient service. It came up in the last 3 or 4 years. I think 2015 it started, to the best of my knowledge, because I started working for one community outpatient service which has overcome many difficulties, as the waiting lists are significantly large in the university hospitals and tertiary care hospitals, and some of those cases are not really needed. They need not be seen in those hospitals. They should be referred to the community centers, and this particular service has reduced the burden to a great extent for 2 reasons. A, that you're sitting in the community, so consultants and doctors come to the community, and the patient does not have to travel far. So, like I said at the beginning, our interest, a physician's interest, a health worker's interest, the top priority is to ease the discomfort of the patient. So if you can save the patient from traveling far by reaching out to the community, nothing could be better. So this concept, community outpatient service, is gaining great popularity, particularly as there is the aging population. They find it quite appealing because traveling for elderly people, and I see in my clinical practice sometimes people about 85, 90 even, and for them to go to the hospital it's burden. It's a great deal of burden on them. So if the community outpatients can provide the service next to where they live, in a community center or general practice or community well, basically the community care centers, then this definitely facilitates them, and they like it so much. Also, this community outpatient service has reduced the overcrowding of the hospitals because these patients need not go there. It's more like outsourcing. The service is provided by different specialists in a community setup, with easy access by public transport. So that's also an advantage, that you don't have to worry about parking fees and finding a spot. Sometimes in a particular place where I work at the present moment, parking is a great nuisance, and really it's tough. So traveling by public transport, by underground or bus, is very convenient, and location is ideal for people to just walk in. Now this, I think, is a great service. Now, The present situation is that cardiology, dermatology, ENT and audiology, radiology are currently available in various community outpatients in England. Now it started from, I think it was, when I joined it, it started in the Midlands, in Peterborough and Lincolnshire, and of course then it went to other places like Cambridge, became very popular. London has gained immense popularity. There are several centres where the services, and then it's gone. Recently it's come to Birmingham and Manchester and expanding rapidly, because these services like cardiology, dermatology, ENT, audiology and radiology, they can be easily covered. Majority of these patients can be seen in the outpatient, and those who need referral for further studies, investigations or onward treatment like hospitalization, etc., they can be triaged from here. It has gained very great popularity, like I just said, because of the convenience of traveling and easy access. Besides, the overcrowded outpatient department of university hospitals feel somewhat less burdened, because routine cases are transferred to the community's outpatient service. This service can also triage the patients needing other services like surgery or hospitalization or other things. But majority of times, particularly in my field, which is ENT and audiology, you can see the patients on the spot, make a decision, carry out it's like a one window operation. You decide what is to be done, either you treat the patient topically locally or you refer, and therefore you save a lot of botheration to and lessen the burden on the health services. Now, moving on, communication skill is a very important aspect of medical care, whether you're a physician or you're a nurse practitioner, and of course, as a patient also, communication skills are important. But I'm addressing basically right now to the medical professionals, and they know it very well that history taking is the beginning of the first consultation. So it starts with the history taking. So facing the patient, and now why did I mention that? But these days the paperless society has forced us to look at the computer while we're taking the history. My recommendation, I'm an old-fashioned person, I still feel it's best to talk to the patient face to face and then make notes, because the eye contact, the body language, these are important factors. So history taking is an important aspect. And the first thing that you do is you greet the patient when you come in. As the patient comes in, you greet him by salutation, by taking the name or hello. In the UK, it's mandatory to use the name. We use it all the time, Mr. So-and-so. In the developing countries, unfortunately, it is still not a practice. You just say salutation and please have a seat and then start. But I think to get to know a patient by name is very, very valuable. Now, through long association with our seniors and peers and colleagues and learning and going to courses and workshops, we learn the art of communication. But nobody is perfect. We're constantly learning. We have mistakes. But hours of learning, observing and applying the art from their masters, seniors, etc. and peers makes a physician or health practitioner quite competent to communicate freely. For example, to open the door as the patient walks in and greet with a smile and a salutation is almost imbibed in a health worker's personality. You don't have to teach this, it just comes naturally as a health practitioner. Body language is important. It can make a huge impact in public life. A positive gesture, body gesture that is, cultivates friendship and understanding. Conversely, a negative or somewhat withdrawing gesture can raise concern. Very important. How you sit in the chair, how you lean your head forward towards the patient or talk to them or make gestures, body, hand movements, etc. In some cultures, the hand movement is absolutely phenomenal. But the others, not so. But it's important that you have a proper body gesture. And body language can convey the message. It's like more like wireless, that the message goes to the other person who's a listener or in the environment. Now, this is a very important aspect. Self-space. Everyone must have a personal self-space. So in consultation, a respectable distance is maintained. It should neither be too intimate nor too withdrawn. And of course, in consultation these days, we have an arrangement. We have a chair and a computer, and the patient sits on one side, usually on the front side. And that distance is... now, in public speaking, there is a special formula, and one of the discussions on communication skills, I have mentioned, I can't remember it offhand, but several feet that you have to keep the distance. eye contact is a very important aspect. So you talk to the patient, or to the, if you're a health practitioner, you talk to the patient making a good eye contact. That is an important, essential part of communication skills. It brings in due warmth and understanding between the two parties. The lack of it may inculcate doubts. If you're avoiding eye contact, you're looking, not looking, or if the patient, that's also the important thing, the patient not looking, not making eye contact, avoiding this thing, looking here and there might be something which is hidden there. So the body language and the eye contact give you a lot of information about the patient's personality and some hidden secrets, which as a physician, as a health practitioner, you would like to know. So eye contact is an important observation. Most important thing for a physician or health practitioner is to listen and observe. Listen and observe. The patient is encouraged to spell out all the elements concerning the disease, expecting a return diagnosis and treatment. Of course, listen carefully. Listen carefully. That is the message. Pay attention to what the patient is saying. That's important, because listening and hearing are two different things. Well, the patient is saying, oh, you're not listening. Mind is not perceiving. So that becomes very difficult when you want to reach a conclusion. And observe the movement of the patient, body gesture, head movement, eye contact, things that I just mentioned. All those important, whether the patient is fidgety in the chair or is uncomfortable. Try to find out. These observations are important and relevant in arriving at a certain conclusion. Privacy is important. Most consults are one-to-one, at least in the UK. In the Eastern culture, usually there is somebody of the family member or somebody who comes in, and that's acceptable because that is the cultural thing. In terms of confidentiality, privacy is important. One-to-one consult is the best way, but patient has a right to bring in a chaperone and request for one, and that is an important thing for a reason that I'll tell you here. Chaperones are encouraged by most clinical practice in the form of either an HCA, which is a healthcare assistant, or a nurse. It is good in many ways, as it can provide reliable evidence in case of a conflict, but also, more importantly, it assists. For example, if you want to ask the patient to go to the car so he can examine, healthcare assistant is there to help you out. Chaperones are invaluable, very important people. But of course, as the patient walks in, it's the job of the doctor to tell the patient that I have assistant who's helping me, healthcare assistant, could be a nurse, or even sometimes there might be students. So sometimes, and it's happened to all of us, it happened to me recently, the patients sometimes, they're anxious at looking somebody else other than the doctor sitting there, and he actually asked me, why is this person here? I said, look, she's my healthcare assistant, and I have to do so and so, such and such procedure on you, so I'll need help, and she has to be a part of it. So you just explain to them. It's important that the patient should be made relax with a word of reassurance, a polite smile, even a gentle touch on the shoulder, just a little pat, may be helpful in allaying the fear and building bridges for future discussion, because unless you have confidence and understanding, it becomes difficult. Now, in the UK, since it's a multilingual society, we have visitors, patients from all over the world. There's so many languages. It should not be a barrier. That is the objective. In terms of consultation, language should not be a barrier. Also in the developing countries, people come from far-off areas like Sindh and Balochistan and Pathan, and same applies to other countries where different languages are spoken. So when the patient comes, the barrier should not be on the basis of language. You have to find an answer. The answer in the UK is very simple. English is the main language, but if the patient finds it difficult, please do not insist. Find an interpreter. The official interpreters provided by the services, health services, they're either available in person or there's an online service. So you have a code, call that number, give your code, and then patient ask what language you want the interpretation. That service will provide interpretation through a professional interpreter, and that's important because unless you have proper detailed history, you cannot reach the diagnosis. So currently there are online interpreter services which are available in the UK, and I'm sure it's available in the US and Canada, other countries as well. Then Google Translator is being used constantly by some people. I know a colleague who does that all the time. So there are different tools which are available. Family members may be avoided as the impacted disease may or may not be presented appropriately. There is a concept of sympathy that, look, the pain, for example, a doctor says, the mother says the pain is intense, agonizing, can't sleep, which may not be true. It may be because of the love for the mother that relative is trying to aggravate or exaggerate. So I think it's advisable not to, but sometimes you have no alternative, so you have to accept those, but be very careful. That is my message to the physicians and young doctors or students. The interview or the consultation goes stepwise. The first and foremost aspect is getting to know each other, as I just mentioned. In the UK and USA, patients are often called in from the outpatient, from the office, from outside, by the doctor himself. Now, this is out of respect. So you go out and call the patient by the name. It doesn't happen in the developing countries where, unfortunately, it's a doctor, well, not unfortunately, it's a doctor's privilege anyway, to expect the health assistant and nurse to call in the patient. This is more like a cultural thing than anything. But in the UK and USA, we encourage you to go out and call the patient by the name, open the door, make him sit. It eases the conversation, develops a good relationship. Anyway, so like I said, the consultation starts with proper salutation, greeting, etc. Sometimes you pull out the chair and make the patient, especially the elderly patients, you have to be very, very respectful. Now, everything is paperless at the moment in the UK, and I think it's gradually happening in the US, in the developing countries also. In the US has been for a long, long time. And the data is recorded, so I have to mention here the electronic record is safe and becoming progressively more and more safe. But even then, we hear many times these stories we learn through newspapers and discussions that sometimes the data is either stolen or it's lost because of cyber attacks, and that is a serious crime which the governments are tackling at the moment. One has to record the details systematically in an organized fashion, taking your time, be careful, and of course many times there's spelling mistakes which should be avoided. Currently we're using System 1 and MS, which are very helpful. And like I said, the electronic data collection is reliable, it's safe, and every person who uses these systems has a dedicated password and should be changed. In fact, it prompts you after every 2 to 3 months to change your password. Then the data is recorded in the form of tab journals, and all these details are available at the time of consultation, particularly at the time of review, because you cannot remember all that you've discussed in the past, so best is to go back and look at it. And then the investigation that requests like radiological or CT scan or MRI or diagnostic blood test or what have you, it goes electronically to the relevant department. So you write out the details, push the button, and it goes straight away to the relevant department. It saves the patient from waiting times. If those services are not available, like in many developing countries, then you have to fill up the form, send it. It takes a while, so sometimes it may be cumbersome. If there is an urgent referral, for example, suspected malignancy, then the transfer of the data and the information, request for an earliest appointment is carried out electronically immediately. And this is here, I've mentioned the form of urgent referral, that if it's a most urgent situation such as suspected malignancy, then 2-week referral enables the physician to instantly send the request to the relevant department, and then you should follow it up, send a letter to the family practitioner that this is what's happening, and you need to follow it up. The electronic copies of investigations are recorded and on subsequent visit discussed with the patient, and a copy sent to the GP. And many times I like to give the record to the patient himself as well to keep for safekeeping and future recording. For example, auditory, if you're doing audiological investigation and somebody has a history of long-term problem of hearing, you want to maintain the record. So the patient is given a copy of the audiogram, can come back next time and you can compare the result. Of course, you have the data, but sometimes the computer glitch can be a problem. So it is best to give a copy to the patient, whether a CT scan or any other investigation. Paperless society, this is what's happening, of course. The papers are not available anymore. It is advisable, and it's mandatory, in fact, not advisable, mandatory, that no results or data may be shared with anyone else without a documented consent of the patient. Only the safe emails you should be using, and we have this NHS email which is safe, it's nhs.net, and that data should be transferred through that network. Other email sources are dicey, as everybody knows about the leaks and problems that can arise. In most other countries, safer emails I'm sure are available, which I'm not aware of, but otherwise the alternative is to have paper files which may be sent through a courier service or a reliable person who can take it from one place to the other. A one-to-one consultation means that if there is an observer, a student or an assistant attending the consultation, permission must be obtained from the patient, who has a right to disallow a third party, because there is a question of privacy and confidentiality. So in medical teaching, if you have students as we have, we tell the patient, look, I have this group of students or 2 students or a health worker or whatever, and they usually give a permission. Sometimes they object, and there is no question that you carry on. In surgical cases, the patient has full right to seek the opinion of the best surgeon, who must discuss and document each and every detail on the paper, on the form, on this electronic form called informed consent, including the planned as well as foreseeable additional procedures. Sometimes you start a procedure and you might have to do something else, so you try and mention each one of them, which to the best of your knowledge as a physician you can document. Complications must be discussed and documented, and this is unfortunately litigation has become a big problem, so every little complication that you can foresee should be mentioned. Anything is spoken but not written down carries no bearings. It must be documented. If a patient is to be operated upon by a trainee or a junior doctor, then the adequate supervision by a qualified competent surgeon is important. That particular surgeon who's in charge of that particular treatment program is basically liable. So he has to be careful and observe the activity of the junior partner of medical profession. Always you have to teach and train others, so you observe the certain guiding principles. Prognosis needs to be mentioned, so there are conditions where you know that prognosis is extremely good. You say, look, this is a simple matter and it will resolve. But if the prognosis is guarded, be careful. The words have to be chosen very carefully. And that's a part of your medical consult. It must be discussed frankly and in simple words. Avoid technical medical jargons. Sometimes the patients require rehabilitation, like after surgery, particularly in orthopedics or cardiac surgery or even cardiac disease. So it should be explained to the patient, mentally prepare them as to what is to happen afterwards. This patient has a right to know the details of duration, the type of therapy, any possible complications, and if it's financial private, then you have to tell the financial involvement, commitment what it would involve in terms of financial expenses in that treatment. Now, if you want to refer a patient to like I said in the beginning, one should know the limitations. You're not competent enough to do everything. You can do your best in terms of your specialization or your field of practice, but many times you have to refer the patient. So onward referred has to be discussed with the patient, and matters should be very clearly explained, the reason why you're referring and to whom you're referring. If the outcome of a procedure turns out to be poor or worse than then the patient has a right to discuss what went wrong and what can be done to remedy it. It's your job to explain in detail and explain with confidence, with trust, with understanding, with empathy, with sympathy. An onward referral or a second opinion is both patient's right and your as a physician, your obligation, because if you're saying that onward referral is needed, it must be carried out. If there is a complaint which arises as a result of treatment, consultation, follow-up, etc., then it should follow there are certain protocols that one has to follow. The matter should be reported to the senior manager or person in charge of the service, and you try and qualify, justify, and mistakes can happen to anybody. Mistakes are common, and one should avoid them as one has to. But many times, if there is a complaint, the best answer is talk to the patient and discuss and explain what went wrong, what is the reason. An apology does not belittle a status, and if you can save a situation by a simple apology, look, I'm sorry this happened to you, it was not out of my deliberate effort, it just happened because something went wrong, and I apologize sincerely, and I'll try to arrange as best I can for onward referral, further management, further treatment. So the complaint, but there is a protocol that you have to follow. A patient is obliged to inform the management of latest, but this is very important because people are moving around. So one has, it's the patient, it's the obligation on the part of the patient to tell the health authority about the latest personal details, correct name, date of birth, address, with postcode and contact phone numbers. You should also tell the doctor of any known allergies such as nut allergies or drug allergies or history of anaphylaxis. If there has been any history of insertions like catheterization or stents or embolism or any serious infections, all that has to be informed. Or in the past, MRSA used to be a big problem. So all those HIV and things like this, everything has to be documented. This is the patient's obligation to inform the health authorities. The respect has to be bilateral. It is sometimes seen in the UK that, and this is a sad thing to say, that when a mother will instruct her child to show the leg or the affected part to the patient, to the doctor, he would say, so and so, show your leg, show your hand, show your ear, to the man. Now that man is a doctor. I think it's mutual respect. If you call him doctor or Mr. or somebody or Miss, then I think it's a mutual respect. But no need to be offended. It can happen to anybody, anywhere. I think education could be one of the reasons, but many times it happens. I think the respect is an important aspect, and I think physicians earn the respect because of long and enduring efforts, learning, educating, keeping themselves up to date. So at least the minimum a patient can do is be respectful and call him Dr. So-and-so, and if you're a surgeon, then Mr. So-and-so or Miss So-and-so. It is just an observation that I thought I'd mention here. Always keep the appointment. This is an instruction, a request, a pledge, urging the patient to make an appointment. And that, please, make an appointment. If you have an appointment, do not cancel it. Do not become a DNA or do not attend, because that is a nuisance. It costs money to the NHS if you cancel the appointment or do not turn up for the appointment. Come at least 15 minutes before the appointment time, because it may take a while for you to settle down and the nurse to come in or doctor to call you in. So it's important. Failure to attend is called DNA. It's not DNA of the protein or molecular biology. It's did not attend. That's the terminal acronym we use in clinical practice. It is not only a waste of an appointment, also costs at least £100 to the NHS currently. So do not do that. If you have a reason not to attend because of some engagement, inform the service manager that could you kindly make another appointment, I can't make it today. And if you're running late, give them a ring and I'm sure they'll oblige and wait. Currently the waiting time before you call it a DNA is 10 minutes. Compliance is important. Compliance instructions given by the physician is important. So if you tell the patient to take a certain medication and if it doesn't comply, then obviously that medicine is not to work. Diet, exercise, all the elements which are part and parcel of physical consultation, physician's consultation must be observed and given due priority and importance. Unfortunately, there are certain bad social habits, and I'd like to mention particularly of smoking, which fortunately is on the decline. But even now, if you go around anywhere, you find that people are smoking, and that's a bad habit. You have chronic smokers who come in, and they fail to give up. In clinical practice, it's important. We tell our patients all the time that smoking is bad. They know it, they accept it, but sometimes they fall. NHS has a dedicated service to quit smoking, but unless you have a will, you cannot have a way, you cannot succeed. West has gotten rid of this nasty habit to a great extent. There has been a significant decline in smokers, at least in these countries, but unfortunately in Africa, in Southeast Asia, and China, it is a major problem. China is a progressive country, and I'm sure they'll get rid of it sooner than later. Indo-Pakistan are facing dual dilemmas of tobacco in the form of smoking, which leads to lung cancer, and chewing form in the form of pan and betel nut, which leads to mouth cancer. And both these things must be stopped, and these are bad habits, bad social habits. Now, another thing I'd like to mention here is that if you're doing consultation, nothing can be more irritating than a phone call during consultation. So physicians are obliged, and we follow the instructions by the health authorities and our managers, to keep it on quiet mode or vibration mode, because during consultation it is not advisable to respond unless it's an emergency, or if you're on call, that's a different matter. Likewise for the patient, it's advisable. We encourage them not to keep the phone on, and if it rings during the consultation, that is definitely a distraction, and it takes away a few minutes of important doctor or health worker's time, so that should be avoided. Like I mentioned in the beginning, informed consent is an important thing. Once the history has been taken, which takes a few minutes, the next step is the clinical examination, the physical examination. That is not simple. It's a major subject in its own right. I cannot cover it now, but some other time, because the time is run out. Informed consent is a major ethical principle, and I'll talk about it as a full lecture at some stage. Autonomy is one of the basic pillars of bioethics. The other three are beneficence, non-beneficence, and justice, and I've discussed in the past. I'll discuss it again. Informed consent is an integral part of clinical intervention. So after you've done the history taking, before you embark upon clinical examination, you must take informed consent, and that informed consent in most routine clinical examination is based upon verbal consent. You don't have to write down that you explain to the patient that you want to do a clinical examination, like measuring your blood pressure. It's called implied consent, that you do a measuring blood pressure or examination of patient nose and throat, or doing some simple measurements, taking weight, etc. That is accepted as a routine thing, so it does not require any written documentation. Implied consent or verbal consent is good enough. But if you're doing anything more than that, for example, you want to carry out any tests or any further investigations, or you do, for example, any maybe a bronchial lavage or a biopsy or frozen section or even endoscopy, then a proper informed consent has to be carried out. Now that's a subject in its own right. Now these are some of the references that I have given here, because they are my sources of information. So I think I will just cover up what I've just said in the next 5 minutes, because we've run out of time. That the important thing to remember in any kind of medical consultation, either you're a physician or a health worker, and from the point of view of the patient, to know these obligations, these rules, that there are certain etiquettes, manners which one has to observe. Doctor, a health worker, a health professional has to be a professional. Professionalism is the fundamental brick of any medical consult or medical care. And like I've said in my discussion, that certain elements have to be kept in view. For example, consultation should be based on mutual respect, dignity, honor. Simple, non-technical language must be used. Any technical jargons must be explained to the patient or to who are. Now the important thing that I also mentioned here is the cultural aspect of surrogacy. Many times the patient is accompanied with a family member, and that is called shared consent, and I'll discuss it when I have discussion about the consent. That is acceptable in the Eastern culture. It's a part of culture. It must be respected, that if a patient comes in with a family member, we honor them, welcome them. We tell them that you are welcome, but privacy sometimes is of paramount importance. If the patient wants to discuss something in private, then I think you excuse and maybe go to a different corner or a different room and have personal discussion. Privacy, confidentiality, trust, autonomy, informed consent, the formula of going into details, investigations, etc., prognosis, long-term management, the outcomes that you expect. If any surgical involvement is carried out, every step must be very clearly defined as to what you're planning to do, what could be the foreseeable outcome if you're impending or you feel there might be complications. Always document them. Every little detail has to be documented, because unfortunately the society is changing rapidly. What I've mentioned here is the 4 models of relationship developed by a certain group. I gave the reference earlier on, that paternalistic approach, then you have interpretation of data, observationship, you have a deliberate discussion. But my personal experience is that it's best to have mutual discussion. You take the history and take the patient to full confidence, and sometimes it's best to guide them through, because not everything is known, and you as a physician or a health worker are knowledgeable. So like the elder member of the family, you guide them through to reach a certain decision. And I would stop here because this has been a long talk, a very useful, informative discussion, I hope, for the benefit of physicians in general, medical students, and a part of the encyclopedia that we're developing. But also I hope it will be helpful to the general public to learn their rights as well as obligations. Thank you, viewers. We'll meet again inshallah soon with a different topic. Thank you and Khuda Hafiz.